Advanced Picture Theory 2, Unit 3, Part 8, Pediatric Cardiovascular System. By the way, how are things going in clinical with you guys? Any good experiences?
Intubation was fun to learn. Just wish we had a few months doing it to really master it.
How many intubations were you able to get, Andrew?
This Charles, I was able to get 22.
Sorry, I was looking at it was Andrew's name that was flashing for. I think he was writing 22. Okay, that's not bad.
I got to do one pediatric, 1 4-year-old, so that was good.
Oh yeah, good. What did you find
Charles.
different about the 4-year-old?
Obviously, a lot easier from the standpoint of actually lifting the jaw and visualizing the chords. I don't know if it's a universal feature of pediatric airways or because this kid had tonsillitis, but I found the tonsils really obstructed the view and really something I had to work around with the tube. And then obviously a very large epiglottis. Just a lot more there to get your tube caught up on that I had to kind of learn to.
And
gently.
Was the anesthetist? Did the anesthetist put more emphasis on going into the right side of the mouth and moving the tongue out of the way?
That was emphasized throughout. Actually, the habit I ended up developing was actually to tilt the head 45 degrees to the left, and then tilt the blade 45 degrees to the right. Insert that way, and then bring them both back to midline at the same time. And I found that was a really helpful technique for me.
Oh, that's interesting. No one's ever described that to me before. That sounds interesting. Very good. Sorry, Andrew, did I cut you off?
No, it was Adam. I just met Charles's really short anesthetist the other day.
It was a great learning experience for me. I was doing well, and this one day I was struggling. I was missing easy tubes, and I just couldn't figure out what it was about this one room that I just kept missing tubes in. And then by the end, the anesthetist finally figured out she was, I'd say about 5'1" max, and I'm a little bit taller than that. And we finally realized at the end of the day that she had the bed positioned quite low. She said, I watched you stoop over and struggle to hold the head up all day, and finally we figured out why. And once I got on the fact that I need to not be shy about adjusting the bed, things improved significantly.
Oh, that's good. That's interesting. Anyone else have any interesting experiences in clinical? And just remember we're being recorded, so try not to reveal anything that compromises privacy.
Not critical, but Josh
Placebo and nitrous oxide causes laryngospasm.
Cool.
Yeah, I've heard that. Sorry, someone else was talking there.
Yeah, so not so much clinical, but Josh and I were in North Carolina, and we're able to have a cadaver lab where we were able to intubate and see the cross-section of the bodies and how the intubation is functioning to the IO. You can see the subclavian arteries taking the actual fluids. You can see the lungs inflating, deflating. It was really neat because it emphasized the benefit of PEEP. It emphasized the benefit of kaleidoscopes. And it was a really cool lab for us.
That's very cool. What was this course called?
We were in North Carolina for the EMS conference.
For the which?
In Charlotte, North Carolina. The EMS Today conference.
Oh, the EMS Today conference. Wow. So this was a pre-conference course.
It was actually a mid-conference
okay.
thing. They had all the cadavers in a conference room in the conference. It was very interesting.
That's fantastic. That's great. Okay, well, let's get started.
I'm sorry, Rob.
Yeah.
One thing I wanted to raise that came up in clinicals that's pertinent to what we're about to discuss. One of the anesthetists, when we were discussing pediatric airways, suggested that the previous understanding of pediatric airways being conical in shape and the narrowest point being at the tracheal ring was actually now being thrown into question. I had a look at some of the research, and I'm always hesitant about jumping on the newest article, but I did read some research that sounded like this perspective is being challenged. That in fact a lot of ICUs and anesthetists are using cuff tubes in pediatrics as a result. I was wondering if you had if you read anything, or if you what your thoughts were on that.
Yeah, I've read similar things, and there has been discussion about using cuff tubes in pediatric patients. I'm not sure whether we're going to move that direction or not. And everything moves very slowly in our business, as you know. I mean, this normal saline versus balanced solutions was all over the Twittersphere and the social blogosphere, etc., a week ago, and whether we'll switch to something like Ringer's lactate. I could see that happening in 5 years' time. Things are just move so slowly in our industry for some reason, and yet air ambulance. We were using Ringers back in the 80s, and they're still using Ringers now as a preferred solution. So I don't know. Things are slow. Cuff tubes for kids. Lord knows. Honestly, don't know. But we'll just make do with what we got for now, I guess. All right, let's move on. Let's talk a little bit about pediatric cardiovascular. So, starting with hemodynamic status, one, important to remember that shock is a hypovolemia rather is the most common cause of shock in kids worldwide. So, one of the leading causes is motor vehicle collisions, and shock often results from either some sudden hemorrhagic volume loss, burns, which is a more slow loss, and important to keep it in mind. We'll talk about burns separately later, but the slower the fluid loss, the slower the fluid resuscitation, and I don't necessarily mean resuscitating over hours versus minutes, but for example, in a kid who is volume depleted because of burns or diarrhea and vomiting, for example, where we might, in a hypovolemic patient, give a fluid bolus of 20 cc's per kilo over 15 minutes. With burns and diarrhea, vomiting, we might be looking at 20 cc's per kilo, maybe over an hour, over 2 hours instead of over 15 minutes. And we have to, be really cautious about putting them into failure and or causing cerebral edema. Other causes, diabetic ketoacidosis. Again, this is takes place over a longer period of time. As I mentioned, we'll talk about burns, but generally speaking, if you've got a patient, for example, with 50 to 60% body surface area burns, and they're hypotensive, they got a pressure less than 2 times the H plus 70, it's more likely hemorrhagic internal bleeding rather than the burns that have caused the volume depletion, because it takes a while for fluids to end up in the interstitium in burn patients. It could take hours. Poisonings would be another one. So hypovolemia, again with kids, important to keep in mind that because they've got a small volume, they lose a large percentage of blood quickly, and the way they compensate is very different from adults. They compensate with minimal changes in BP, for example, and then very, very suddenly deteriorate. So one of the concerns I have with the current medical directive is this whole notion of 20 cc's per kilo when the pressure is less than 2 times the H plus 70. My concern with that is that if you wait till the pressure drops below that parameter, it's way too late in the game. You're way too far in the game. And I think if you've got, my advice to you guys is that if you've got a pediatric patient who is has any signs of volume depletion, let's say from internal hemorrhage, they're pale, they're cool, they're restless, they are tachycardic, but their pressure is above 2 times the H plus 70, I would patch for an order for fluids. And if you get it, you get it. If you don't, then you're sharing the medical legal responsibility, right? So there's you're advocating for the patient, really. That's what's important. I'm just looking at Chris typing. I'm just waiting for something to come up here on the board. So Chris writes, because they have a small volume and lose it quickly, should we routinely check blood sugar? in all pediatric traumas. Well, I don't know if that's necessary, but anytime there's an altered LOA, I would check blood sugars. Why were you thinking blood sugar because of the small volume? Excuse me. I'll just keep moving on until I see your response. So, obviously, we want to quickly gain control over external hemorrhage and get that under control. And because it compensates so well, it makes recognition shock a little difficult. But in most cases, you should be able to tell when someone is sick. And so we want to start to manage them before they suddenly start to deteriorate. Now, just out of curiosity, I've had two patients in particular, two pediatric patients in particular, who were bleeding internally and crashed on me very suddenly, and two others who were not quite as subtle. Have any of you had a pediatric patient who, with that experience, where they've crashed very suddenly? And I've see Tanya's got her hand up. Oh, sorry, Tanya. Let me give you your. There we go.
Good morning.
Good morning.
I was more thinking along the lines of when we were talking about the age times 2 plus 70 for determining whether or not they're hypotensive. We also have the other one of the age times 2 plus 90 for normal tensive for the children. So that in between, like for instance, age times 2 plus 80, they're already decompensating, right? So that's probably a better time to patch rather than waiting until they're under the 70.
Yeah, absolutely agree, 100%. Yeah, whether they're decompensating, compensating. I look at it this way with adults. My way of thinking is if they're less than 90, they're decompensating. So if their pressure is decent, they're tachycardic, they're compensating up until that point. It's really an academic argument at that point, but I couldn't agree more that I think that when kids are in that gray zone, that's when we need to patch and get an order for fluids for them. So kids will maintain their stability or their hemodynamic status largely through an increase in heart rate, especially under the age of 8, because they don't have the same degree of contractility to force of contractility to compensate for volume depletion. So they'll remain tachycardic and then very suddenly deteriorate. Whereas adults, we typically see relatively slow, steady, and predictable decline in their BP with an accompanying increase in their heart rate. So BP is a poor indicator of volume status in kids, and we need to look for other things. In things like dehydration, we look for in infants, sunken fontanelles, in sunken eyes, in older children, dry mucous membranes, poor skin durcor, those sorts of things. Peripheral pulse rates and quality, skin color, temperature, level of consciousness. LLC is a good indicator of early volume depletion when they start to get restless, and if they're truly altered, then they're probably way down the road of decompensation. So we look at cap refill greater than 2 seconds as well. In terms of management, we want to get IV access en route and rapid fluid resuscitation, 20 cc's per kilo over 10 to 15 minutes if it's hypovolemia. The ministry's put the Buretrols back on the trucks, I noticed, and I know we started carrying them about a year ago. I don't think I'll ever use a Buretrol. I much prefer a macrodrip tubing with a 500 cc bag and a flow regulator. I think so. Peel carries the flow regulators. We carry the flow regulators in Halton. Is Toronto carrying the flow regulators?
Yes, they are.
Okay, good. Yeah, those have been tested in the neonatal units and the pediatric ICU units at McMaster Hospital. That's where we first learned about them years ago, and so they're pretty darn accurate. And I think much easier to handle than trying to set up a Buretrol that you might set up, once a year if you're lucky. Someone's going to say something.
I believe in Toronto we only use one drip set. I believe it's the macro. Well, I can't quite remember actually, but it's one of them.
Yeah.
Yeah.
So you use macro drips.
10 drops with macros, 10 drop
Yeah.
sets with
Right.
liter bags.
So we have to use the Buretrol. We have to use the control. There's certain pops.
Sorry, where do you have to use a Buretrol?
I'm saying if we wanted to better meter the dose because we don't have a micro drip, right?
Yeah, but didn't you
That's
say that you have the flow regulator?
We do.
Yeah, Andrew, Buretrol is standardized equipment now. Yeah. I won't use it though. I'll use the flow regulator instead of the Buretrol. Okay, but if your service is saying use a flow regulator, or your base hospital is saying, if your base hospital is saying use a Buretrol, then by all means use a Buretrol. So briefly, burns in kids. So thermal injuries result in loss of fluid through the burns, and massive histamine release causes fluids to third space to end up in the interstitium, and it's greatest within the first 12 to 36 hours. So again, the emphasis here is on this idea that if you're dealing with a child with a large body surface area burn, but they're hypotensive, then you're most likely dealing with some accompanying trauma as well, and blood loss because of the trauma, not specifically because of the burn trauma. So management with burns, we use universal precautions to protect them from us because they've lost that barrier protection, their skin, and so we wear a mask and gloves to protect the patient and manage the burns as per BLS standards. IV access en route, and we use the Parkland burn formula. Now you read in some textbooks it'll say anywhere from 2 to 4 cc's of normal saline per kilo per percentage body surface area burn, and you give half of that over the first 8 hours, but it's really not 2 to 4, it's 4 cc's per kilo. And I've spent quite a bit of time on the burn unit. Well, I say quite a bit of time, I spent about 5 or 6 days over a few years. I just enjoyed going there. I found it was a really good learning experience. And what I heard consistently from the burn unit staff is that outlying hospitals and paramedics typically overestimate. This is somewhat contradictory, but interesting. So we typically overestimate the body surface area involved. We typically under fluid resuscitate, and typically under medicate in terms of pain management. So I thought that was interesting. And sometimes outlying hospitals will under fluid resuscitate because they use the 2 cc's per kilo per body surface area instead of 4 cc's. Because you think about that, that's literally half of what the patient should be getting. So on that note, and we'll come to burns, back to burns as a separate topic, but if you're encountering a burn patient and you're looking at the burn formula, two things. One, it's based on the time that the burn happened. So if the burn happened an hour before you got there, then you're doing a little bit of catch up. And two, you should be calculating the burn formula before you patch to base hospital physician. And I would just say to the base hospital doc, I've calculated the Parkland burn formula at 4 cc's per kilo per percentage body surface area, and my calculation would suggest that we run it at this amount per hour. And just to answer your question, Andrew, I believe the reason why peripheral hospitals and paramedics sometimes under fluid administer is because they're basing it on 2 cc's instead of 4 cc's. Does that make sense?
Yeah. I had another question. When you say catch up, if you're showing up an hour or two later after the burn's been happened, are you bolusing that, or are you just giving that first half of the fluids in, say, like 6 hours instead of the 8?
Yeah, that's exactly right. You're averaging out over 6 hours instead of 8. Yeah,
Okay.
instead of bolusing it. Now, would it be a big deal if you bolused it? Probably not, but that's a conversation that we have with the base hospital doc.
Okay.
Yeah. And ultimately, I can call a base hospital doc and say, look, I've calculated the Parkland burn formula, and it recommends that I give 800 cc's per hour, let's say. And the base hospital doc might say, that's fine, but I just run a TKO. And, if the patient's not significantly volume depleted, my answer would be, okay, sure, that's fine. And then the hospital can deal with catching up with the Parkland burn formula. So Chris's question about kids, we always have to be a little bit cautious about kids and fluids, and but again, in the field, if we're dealing with a kid who is hypotensive, we're probably dealing with some sort of hemorrhage. So a 20 cc per kilo over 15 to 20 minutes is not unreasonable. But if we're talking burns and using the Parkland burn formula, then we're talking about amounts of fluid over an hour. So I don't think there's a lot for us to worry about. So let's say, for example, I'm just pulling out my calculator here. You've got a child who's got 35% body surface area. So that's 4 times, let's say, 25 kilos times 35% body surface area. And then we divide that by 2. And then we divide that by 8. That gives us 218 cc's per hour. That's a pretty low volume, right? So we're not overly worried about giving them too much fluids. But, we're going to monitor them anyway. Keep an eye on them. So there's, I forgot I had a sample there. 15 kilo child with 60 degree body surface area burn, right? So that would be that amount divided by 2 because we're giving half, right? And then divided by 8 because we're giving it per hour. It gives you 225 mLs per hour. Not a huge amount of fluid. So dehydration results from fluid loss at a slower pace. And examples would include vomiting, diarrhea, diabetic ketoacidosis. Electrolyte imbalances are common in those kids, potential for arrhythmias, and maybe altered LOC from volume depletion or electrolyte and or acid-base imbalance. And the management, IV access en route, well, you'd probably get it on scene too with dehydration, a huge rush. And then, so we follow the medical directives. So 10 to 20 cc's per kilo over 10 to 20 minutes. Slower if we're looking at dehydration. So we reassess every 100 mLs, reassess the chest, and the one patient in particular who's a little worrisome is the type 1 diabetic patient who has suspected diabetic ketoacidosis. So the medical doctor requires that we patch if they're under 12 under that circumstance. Another cause of hypotension would be poisoning, such as calcium channel blocker or beta blocker ingestion. It can cause weakened cardiac contractility or acute cardiogenic shock. And management would be IV access, 5 to 10 mLs per kilo bolus. Watch for signs of acute, pulmonary edema. Sorry about that. And they may need high doses of glucagon, so 3 to 8 milligrams of glucagon IV. That means getting a couple of extra crews there. I don't know about you guys, but we carry 2 milligrams total of glucagon, maybe 3. Actually, I think we carry 3 because I think we carry two doses in our backup ALS bag. But maybe just one crew and a supervisor crew. Do you guys know how much glucagon you carry in your ALS units? Four? Okay. That's a good number. And what service is that, Chris, again? Toronto, okay. So in terms of rhythms services, in pediatric patients, rhythms are categorized as either slow pulse, fast pulse, or no pulse rhythms, generally speaking. So that really is a nice way to frame dysrhythmias in kids, so you can think about simple ways of managing. So the urgency will depend on just how slow the heart rate is or how fast the heart rate is, and their systemic perfusion, the patient's overall clinical presentation, particularly their mental status, that sort of thing. And important to remember that hypoxemia is a frequent cause of bradyarrhythmias in patients, so if we manage the airway and breathing promptly, that may eliminate the need for pharmacological intervention with those kids. So as you know, heart rate's less than 100 in a newborn and less than 80 in a child is very slow, so we manage with airway breathing and look for signs of hypoperfusion, altered LC, agitation, poor skin color, delayed cap refill, and normal BP would be 2 times the age plus 90. Low BP, according to your directive, is less than 2 times the age plus 70. And we're going to look after the airway, provide PPV, PRN, and if the slow rhythm persists despite adequate O2 and PPV, establish IV access, patch to BHP. If we're dealing with a child, I'm not talking about a neonate, and maybe an order for atropine to inhibit vagal stimulation. So the dose for atropine is 0.02 milligrams per kilogram and no less than a single dose of 0.1 milligrams. And orders for epi, well, first of all, we're not going to give epi intravenously in a kid who has a pulse, but it'd be nice to see epi drips added to our scope of practice. We can't patch for that right now, so don't think about patching about it, but this is fairly standard practice to put a milligram in a liter and run it slowly. Transcutaneous pacing would be another option. The rate's typically set at 100 beats per minute for pediatric patients, but that'll be dependent on your BHP. Yeah, so MJ, I would just run that by your medical director. We've run it by ours, and he's said emphatically no, that's not part of our scope. We're not to do that. So before you go rogue, check with your medical director at a CME. This is the trouble with our directives in general, right? Is you might patch to a doc, and the doc might say, "Yeah, that sounds like a great idea. Go ahead and do it." And you know that's standard practice in medicine, but you know the medical director, on the other hand, will come back and say, "No, I've never said you could do that." So tachyarrhythmias. So sinus tachs are typically less than 180 in pediatric patients. Causes include hypoxia, hypovolemia, hyperthermia, metabolic stress, toxins, poison, drugs, pain, anxiety, and the management is really just treat the underlying cause. So maybe pain management or something like that. SVTs typically have a very narrow QRS, and avinodal reentry is the most common cause in kids of SVTs, and they typically occur in paroxysms. And In infants, SVTs generally produce heart rates greater than 220 per minute and sometimes as high as 300 times per minute, which is what this rate is here on that ECG. And in older kids, we're looking at heart rates greater than 180, which I'll come to in just a second. So most SVTs, 60%, are greater than 230. And clinical presentations, so initially may be well tolerated in infants and older children, and but they can also lead to acute congestive heart failure and collapse. So you got to do a proper assessment and auscultate the chest. So clinical presentation will depend on the age, the duration of the SVT, the just exactly what the heart rate is, and typical complaints include lightheadedness, dizziness if they're verbal, chest discomfort, delayed cap refill. Vagal maneuvers can be used for stable SVT, and this is not actually part of our scope, but our scope is really just Valsalva maneuver or adenosine. But ice packs work quite well on the neck, crushed ice, in a bag of water or in a glove over the neck for a period of 15 to 30 seconds may work. Valsalva may work. It's a little bit age dependent. Carotid sinus massage, I'll just keep in mind that this is not part of our scope of practice. I don't know if it's part of the scope of practice for medics in other province. We did CSM for years and years and years, and then we stopped around the mid-1990s. And I'm just reading a message here. So Andrew, for the ice packs somewhere else recently. Okay, sorry, that wasn't meant to be a question. Yep. So yeah, if you get the opportunity while you're in clinical to see a kid in SVT, I would ask the staff how they manage their SVTs in kids, or just bring it up in conversation when you're speaking with one of the docs or one of the nurses, for that matter. But ice packs work well on kids because they've got a more pronounced mammalian dive reflex. When I was trained at Sick Kids Hospital, they carried ice pea or frozen peas in the refrigerator, in the freezer, and they just pulled those out and wrapped it around the neck. Left it on there for 30 seconds or so to a minute. So adenosine would be the drug of choice in kids, and the dose is 0.1 milligrams per kilogram with a max dose of 6 milligrams, followed by 0.2 milligrams per kilogram with a max dose of 12 milligrams for the second dose. And I don't think you should be expected to memorize these doses, but you should keep them available somewhere for yourself, maybe in a pediatric app. And adenosine, like in adults, is not going to be effective on AFib or flutter or VT. So it's important to make the distinction between SVT and those other rhythms. The need for synchronized cardioversion, same as adults, right? So any signs of hemodynamic instability, like congestive heart failure, altered LOC, poor peripheral perfusion, shortness of breath associated with SVT, and it's rapid, it's effective, it has fewer complications than adenosine or other drugs, which is nice. And the energy settings are typically 0.5 to 1 joule per kilo, followed by 1 to 2 joules per kilo for cardioversion. Again, in my experience, whether you get an order for cardioversion depends on how comfortable your base hospital doc is with cardioverting a child. So just a quick comparison between sinus tach versus SVT. So sinus tach will typically have a history compatible with sinus tach, such as fever, injury, dehydration, pain. P waves are present in normal. Heart rate varies with activity. Variable R to R with constant PR interval. Infants usually less than 220, and children usually less than 180. In contrast, SVT, the history is not compatible with sinus tach. So if you get a kid who's not febrile, he's not injured, he's not dehydrated, he's not in pain, that suggests the kid is probably in an SVT, particularly if the heart rate is greater than 220 in an infant or greater than 180 in a child. P waves are absent or abnormal. Heart rate doesn't vary with activity, so it's fixed. And the only way really to make that determination is not to look at the strip, but to actually turn the volume up so you can hear it. And if you happen to see a paroxysm, then you know for sure it's an SVT, so an abrupt change in the rate. So infants, again, heart rate usually greater than 220, and children heart rate greater than 180 should make you think SVT. VT is uncommon in pediatric patients, and most kids in VT have some kind of underlying structural abnormality with their heart, or they have long QT or recent history of myocarditis, or maybe a history of cardiomyopathy. And so parents hopefully will give you some insight into what's going on with this kid. But other causes include hypoxemia, acidosis, electrolyte imbalances, drug poisonings, particularly things like overdose on tricyclic antidepressants. And management, so you're going to patch to BHP for stable or unstable VT. And stable VT can be managed with amiodarone or lidocaine. Lidocaine tends to work preferentially on ischemic ectopy. Amio works on just anything, so you're more likely to get an order for amio than lidocaine. And unstable VT is treated with synchronized cardioversion. Pulsive VT is treated just like VF with defibrillation. No need to patch, as you know. So management summary. Largely the care we're going to provide is supportive, ensuring the airway is patent, and any hint of an airway problem is life-threatening until proven otherwise, because the airways are so small and compromise easily. And O2 at high concentrations if needed, PPV, PRN. Hypoxia is the most common cause of morbidity and mortality in kids. We control external hemorrhage. If we suspect internal hemorrhage or any hint of internal hemorrhage, we treat until like it's life-threatening until proven otherwise. And remember that shock can be very insidious in kids, and they'll maintain their blood pressure forever and then just suddenly crash on you. How do you know when oxygenation and ventilation are effective? What should you start to see in these kids? What kinds of improvement should you start to see?
Their heart rate increase?
Or, yeah, if they're bradycardic, for sure, heart rate increase, yeah. If they're tachycardic, heart rate might come down, okay?
Sure.
Yeah, GCS improvement. Okay, Andrew, thanks. Anything else?
Well, saturation change, ECG changes. I mean, any of our monitoring should change.
Yeah, okay, so saturations improve. If they've got ventricular ectopy, which would be unusual in kids, that starts to disappear. That's a good sign. Yep. Anything else?
Capnography changes.
Sorry?
Capnography changes?
Yeah, capnography changes. Okay, if you got the luxury of monitoring capnography, these kids. Anything else? Basic stuff? Yeah, so cyanosis improves, color improves. Sorry, someone was saying something, but it was a wash.
Chest rise and fall.
Yeah, chest rise and fall. Good. Yeah. So all the basics thing: improve cap refill, improvement in color, improvement in SpO2, decreased heart rate if they're tachycardic, increased heart rate if they're bradycardic. Yep, good. All those things. Excellent. Okay. And no air entry in the stomach. Color improves. Blah, blah, blah. We only start IVs if absolutely necessary. We want to try to prevent hypothermia in kids because they become hypothermic more easily than adults. Cover the blanket. Use a heater in the ambulance. PRN. What else? Bradyarrhythmias. Ensure airway and breathing is managed. And other options for bradyarrhythmias include atropine, pacing, dopamine. I'm just going to scratch out epi here because epi is probably not going to be an option in terms of our scope of practice. Tachyarrhythmias, we manage the underlying cause. So if we suspect sinus tach, then we I'll do that. And other options for VT, amiodarone, lidocaine, cardioversion, defibrillation if they're pulseless. And that's it. Any questions about the cardiovascular component for pediatrics? I don't think the LP or the Zoll have that capability. They may be able to monitor transdermal temperature, but not CO2 that I'm aware of. Never heard of that. Just waiting for Chris to finish typing before we wrap up this this session.
So, one interesting question. Oh, somebody else.
Sorry, go ahead.
Just about the transdermal CCO2. I saw yesterday's with the Sick Kids team. Amazing technology. I've actually never seen it prior to this, and I know the Zoll doesn't cover it, and it seems like the Life Pack doesn't either. But really, really interesting technology. It'd be cool to see.
And this was transcutaneous CO2 monitoring?
Correct. Yeah.
That's amazing.
Apparently, it's got a very, very high accuracy.
Really, eh?
They're more concerned with it when they're actually taking when they're doing arterial blood gases. They want to make sure that it's within a certain level while they're actually. But just to check its accuracy. But yeah, really, really cool technology.
Wow, that's very cool.
Oh, sorry. On that topic, an interesting discussion we had with one of our clinical coordinators, Aurelia, about a new technology I think we're going to see come down the pipe in the next few years. You might be aware of it. The U.S. military has done extensive studies on exsanguination and changes in capillary pressures and using SpO2 monitoring or similar kind of just sort of that type of monitoring equipment. And they've developed a kind of repertoire of the progression of changes that the machine reads depending on the stages of exsanguination. So they literally took blood out of guys just to the point of arrest, and then immediately gathered the data and then refilled it. So what they've done is they've built a device that can actually can actually give you a reliable indication of the level of shock that a patient is in, simply on the basis of non-invasive monitoring, similar to an SpO2 monitor.
Okay, but not an SpO2 monitor, but something similar. Interesting.
It uses the same basic technique, but it's backed up by being able to run an algorithm off this database that the military's done. So comparing the data coming back from the SpO2 monitor to this database based on an algorithm, and that's going to give you a reliable indication. I think it's a shock index reading or something like that.
Sounds interesting. Very cool.